For the longest time, a 911 call for a mental health crisis really only led to one place, the emergency room. But let's be honest, is a chaotic ER, which is built for physical injuries, really the best spot for someone in psychological distress? Well, a new treat and refer guideline is challenging that whole idea, giving first responders a brand new playbook to get people the right care right away.
And that's the central question right there. Think about it. An ER is full of loud noises, bright lights, and constant urgent drama. That kind of environment can actually make a mental health crisis worse. It often just becomes a holding pattern, not a place for real, specialized care. That mismatch just creates backlogs in the system and can be a pretty traumatic experience for someone who's just trying to get help.
So, the alternative is this model called treat and refer. What is it? Well, you can think of it like a decision-making map for paramedics. It gives them a really clear, structured way to figure out if a patient can be safely and directly connected with mental health services, completely bypassing the ER. And let's be clear, this isn't just some minor tweak to the system. This is a pretty fundamental shift in how we think about emergency response. It's all about redefining what success looks like. It's not just about getting a patient to a hospital, but getting them to the right kind of care for the right person in the right place right from the start.
So, how does it actually work? Well, it all kicks off with a really careful and thorough screening right there on the scene, the moment paramedics arrive.
The first thing you have to know is that safety is always, always number one. So before they even think about a referral, paramedics are treating this as a medical call. They run a full screening exam to get a complete picture of what's going on, both physically and mentally.
And the level of detail here is so important. Paramedics are looking at everything: past psych history, what medications they're on, if they're taking them, any history of substance abuse. And, most critically, they're looking for any immediate risks, like suicidal statements or behaviors that could be dangerous. This is a serious professional assessment, not just a quick look.
Now, let's talk about the stop signs. The whole process has these built-in, non-negotiable safeguards called exclusion criteria. If a patient meets any one of these, the decision is made for them. They have to go to the hospital. No ifs, ands, or buts.
And these are the big red flags. We're talking about things like a brand new medical problem, an active suicide attempt, or someone going through severe alcohol withdrawal. Same goes for any kind of trauma, violent behavior, or if they need an IV. Patient safety is the absolute top priority here.
Okay, so if none of those red flags are there, then the paramedics can move forward. And this brings us right to the heart of the protocol, navigating the actual decision map.
The very first fork in the road is a simple question. Are any of those red flags we just talked about present?
And the logic is just crystal clear. If the answer is yes, it's straight to the ER. If the answer is no, then they can move on to the next step. The next checkpoint is all about the medical side of things. Are the patient's vitals stable? The paramedics do a full workup to make sure there's no hidden physical issue that's just pretending to be a psychological crisis. And they're looking for very specific numbers here. Everything from temperature and breathing rate to blood sugar has to be within a safe, normal range. This is a critical safety net to make sure they're not about to refer someone who is actually having a hidden medical emergency.
And just like before, the outcome is totally straightforward. Unstable vitals mean a trip to the ER. But if the patient is medically stable, the paramedic can then move to the final and I'd say most important question of all.
So after clearing all those medical hurdles, it all comes down to the patient themselves. Are they seeking help voluntarily? And are they able, in that moment, to make that decision? This final question is all about protecting a person's autonomy.
Answering this last question is what determines the final destination, and it's what ensures the patient ends up in the right place, getting the right kind of care. So the two paths are clear. If the patient isn't seeking help on their own, or they can't consent, they're transported to the ER. But if they're medically stable, have no red flags, and they want the help, well, then this new, better path opens up: a direct phone call and referral to crisis services. And the referral process itself is amazingly simple. The paramedic just makes one phone call to crisis resources and gives them a quick professional handoff. And that's it. The patient is now directly connected with mental health experts who can take over from there. And let's be absolutely crystal clear on this one point, because the guideline itself really emphasizes it. Patient choice is paramount. At any point in this process, the patient can just say, "Take me to the hospital," and that request has to be honored. This model isn't about taking options away. It's about adding a better one. So when you step back and look at it, the impact of this treat and refer model is pretty huge. Patients get faster, more appropriate care. Their own choices are respected. And our emergency rooms, which are just completely overburdened, are freed up for critical medical cases. It's just a smarter, more compassionate system for everyone.
This model really is a powerful blueprint, and not just for mental health, but for the future of emergency response in general. It proves that by asking the right questions, we can build smarter, more humane systems. So the final question for all of us is, where else could we apply this kind of thinking?